like to ask Goran Stankovic, one of the motors of the bifurcation treatment in the world. I'm really happy to have him in person this year. So welcome, Goran, and the floor is yours.
Dear Dobrin, I don't know where is Valeri. First of all, thank you very much for the kind invitation. This is, of course, I will continue when what you and Eve started. It's a meeting of friends, very professional one, but with fantastic hospitality. And people keep coming back every year to discuss complex coronary interventions. And I'm always happy to give my presentation in front of a full audience like today. And of course, I wish you a successful meeting. My topic is to update on bifurcation PCI, actually messages from the last TBC document that we are preparing currently, and you can read it in the May issue of Eurointervention, but I'll give you some glimpse into some of the highlights from that one. These are my conflicts of interest, and there are two parts. For younger colleagues, I'll update you on the reports from bifurcation trials last year, and the second part is actually refinement of bifurcation PCI technique that was discussed during the last European Bifurcation Club meeting in Warsaw. So at PCR last year, David Hildig-Smith presented 3-year follow-up results of the EBC main, the most important randomized trial that we performed as the club. Quick reminder, we compared the stepwise provisional and two-stent strategy in a group of patients with true distal left main bifurcation lesion using Resolute Onyx drug-eluting stent. 230 patients in each group. Just as a reminder, in a stepwise provisional group, 1 out of 5 patients, 22% of them received second stent as part of the provisional stenting. These are main results, primary endpoint at 1 year. And then at 3 years of follow-up, still there is no difference with numerically lower rate of events with provisional. And as you may see, no difference in mortality MI, almost double rate of TLR with two-stent strategy compared to provisional. So look the trends, and we are really looking forward to see 5-year outcome, hoping that we will have some clinical evidence in favor of provisional that we strongly believe is really treatment strategy of choice. So there are good outcomes at 3 years, no difference in primary endpoint, and the key message is if you start provisional, then you don't need to decide in advance the number of stents that you will need. Confirmation also at PCR, Rolex registry, Tarantini presented final 2-year outcome, 450 patients, very similar to EBC main. You can also see final treatment to 1 stent, almost the replica of EBC main, 77% of patients provisional, second stent only in 23% of patients, target lesion failure only 5%, even lower than DK crash 5, and only 3 new events up to 2 years of follow-up. Very important finding, imaging further improved clinical outcome. Also at PCR, we presented final 5-year outcome of EBC2. It's actually a study which compared provisional and culotte in non-left main bifurcations, was published in European Heart 2016. MACE was not significantly different, and 16% of patients in provisional had second stent. This is 5-year outcome, still no difference in the events, even if we stratify according to disease length in the side branch, more or less 10 millimeters. So we believe that routine culotte does not improve MACE beyond provisional, and only 1 out of 6 non-left main patients needs actually second stent. So this is our stepwise provisional strategy, divided in 5 steps. I'm not going into details, but of course there is dilemma, do we need to perform routinely kissing? In non-left main lesions, Bernard Chevalier presented KISS trial results, very important study. After POT, if there was no flow reduction in the side branch, he randomized patients to no further intervention versus POT side POT or POT key spot. Endpoint was peri-procedural infarction rate, and there is absolutely no difference in the rate of events regarding myocardial infarction, whether or not we perform further optimization with POT side POT or POT key spot. However, non-inferiority was clearly met, 4% no intervention, almost 60% if we perform intervention. So most probably, if after POT we have T-mid flow, we don't need to routinely do kissing for non-left main interventions. 2023 is the year of imaging. We published as a club consensus dedicated to IVUS, consensus dedicated to OCT, and with Korea and Japan, physiology approach in bifurcations. Last year we have two key trials. One is Renovate Complex at ACC, not directly related to strictly bifurcations, and at ESC, the October, really dedicated to complex bifurcation lesions. Renovate Complex, you can see that it's a large study, 1,600 patients. True bifurcations, PCI of the left main was included, 2-to-1 randomization, image guidance versus angiography guidance, with clear benefit of image guidance compared to angio guidance. And if we go angio versus OCT, angio versus IVUS, there is both OCT and IVUS showing superiority, and comparing IVUS and OCT guidance, there is no difference in the outcome. October was presented at ESC, a large trial, 1,200 patients, 1-to-1 OCT guidance versus angio guidance. Protocol very precisely defined, 3 pullbacks with OCT for optimization. 20% of lesions were left main bifurcations, less than it was expected, and this is the primary endpoint, MACE, that is really clearly positive for OCT versus angiography. So based on October, we can claim that OCT-guided PCI has lower incidence of composite MACE in complex bifurcation lesions. I'm not going into details, but here I'm using slide of my mentor and my personal best friend Yves, and I like this very much. If you read the protocol of October, you can see absolutely every detail how to perform image-guided PCI. But if you need to look how to perform angio-guided PCI, there is not a single word how to do it. So another study from ESC, Guide DES, QCA compared to IVUS guidance for drug-eluting stent implantation, a large trial at 1 year of follow-up, absolutely no difference in composite of mortality, MI and TLR, and we see 67% bifurcations, 15% left main. There is absolutely no difference whether we guide procedure by QCA or by IVUS, and authors of course concluded that for all comer patients, QCA-guided PCI is non-inferior to IVUS guidance. And now I switch to second part, which is optimization of bifurcation PCI, or how to optimally perform angiography-guided bifurcation PCI if imaging is not available. I think we have plenty of data that imaging really improves the outcome, but what about centers without imaging? And this is a set of slides that I borrow partially from Yves, and this will be the basis for our next consensus document that we are currently preparing. And there are a couple of important slides that we need to understand in order to be able to improve bifurcation PCI outcome. First, bifurcation has 3 segments. We can determine precisely diameter for each of these 3 segments by QCA, and look, reference diameter in bifurcations is not linear. There is a step down at every bifurcation point, and dedicated QCA software needs to be used if we want to reliably measure diameters. Very important message, IVUS overestimates true lumen dimensions, and QCA underestimates by 5 to 10% compared to OCT evaluation and compared to actual phantom lumen area. So this needs to be corrected with procedural improvements. Then there is new data on maximum overexpansion off-label, and Gérard Finet and Derimey presented at EBC this maximum expansion capacity data. They inflated 7 millimeter balloon inside stent, and you see that Zions you can open up to 7, Ultimaster Nagomi up to 6.5, and then you can see for other contemporary designs. What is the key message is that number of crowns and peaks actually determines the expansion capacity. So large stent platforms with larger number of peaks and crowns actually has better expansion capacity. Should we perform provisional by selecting always stent according to distal main vessel or proximal main vessel diameter? Very controversial and very intriguing results by Yutaka Hikichi. Of course, in the bench testing, he suggests for left main PCI to take stent based on the left main, on proximal main vessel diameter, deploy it by 3 inflations of maximum 5 atmospheres with good post-dilatation proximally. And for example, in this case, he's using a large 4.5 millimeter stent. He deploys it 3 times at low pressure, and then when you do OCT, you see that distally, with this pressure, you achieve 3.5, and proximally, with post-dilatation, you can come up to 4.4. This is bench testing and, of course, needs clinical validation. Second improvement, and I believe this one is very important, if we do POT, should we start POT from distal, from carina, and go towards the proximal edge, or we should actually change the philosophy and deploy stent and then start POT from the proximal edge and go towards the carina. Look this case example. Deployment of stent. After deployment of stent, we go with the adequately sized post-dilatation balloon, and you see we do it from the proximal edge, and this will actually result in less elongation. By performing from distal to proximal with wings of balloon, when we pull back balloons, actually we expand and extend the stent, and this is publication in neurointervention by Gabor Todt and the group. So maybe we should think, especially for left main, to deploy stent and start post-dilatation from the ostium and go towards bifurcation. And this is the final outcome. Second, we can, with small injection of contrast, like the puff of contrast, when we perform POT, actually estimate whether we have full apposition of the stent, actually whether we really obstruct the flow with the POT balloon. And this is published by Julian Ajic in Eurointervention. So inflate balloon for POT, small puff of contrast, and you will see if there is no contrast distally, you are really adequately sized. And this is slide of Eve that we can also use stent enhancement software, and look in stent enhancement software, we can really see homogeneous deployment and 2 different diameters, bigger proximally and smaller distally. Another important bench testing data, again from the slides of Eve, if we use balloons, balloons have a difference between diameter at nominal pressure and at rated burst pressure. And if we inflate for the first time, we need higher pressure to achieve nominal diameter and actually to reach limited diameter at the rated burst pressure. But if we keep balloon inflated for 30 seconds, when we deflate and inflate again, look the curve, at much lower pressure we achieve higher reference diameter, and you see if we repeat inflation 3 times, actually with only 2 or 3 atmospheres we are able with the same balloon to achieve nominal diameter that we would like to reach. So balloons are elastic but also plastic, and when we inflate several times we actually achieve better stent expansion and apposition. And another publication from Massi, Thomas Ovas, associate of Eve, published in 2013, I think 10 years ago, that it's not enough to inflate stent for 5 seconds. we need to keep balloons inflated for at least 25 or 30 seconds in order to be able to fully oppose the stent, and you can see the benefit of prolonged inflation. So, dear colleagues, I would like to conclude that in 2024, the way to perform provisional stepwise bifurcation PCI is to respect fractal geometry and determine diameters using dedicated QCA software, plus add 5 to 10% in order to reach real natural vessel reference diameter. In case of diffuse left main, we should use Finet formula. Balloons are elastic and plastic, so we need to inflate 2 or 3 times, keep balloon inflated for at least 30 seconds in order to reach nominal diameter, and we can inflate third time to compensate for this 5 or 10% underestimation. There is no need for high pressure for stent deployment. Contemporary stents, which are 60 to 80 microns, can be fully deployed by only 2 atmospheres. So we need to well prepare the lesion, and then we don't need high pressure for the deployment. Actually, we need to work more on lesion preparation, and in that case, we will have much better stent expansion and apposition. For left main bifurcation, if we do provisional crossover, according to Dr. Hikichi and bench testing, we can select larger stent diameter, deploy it at low pressure, 3 inflations only at 5 atmospheres, and then proximal pot 3 times 30 seconds. Stent apposition can be verified by pot puff, small contrast injection, or stent enhancement, which now almost every cath lab has. Final stent enhancement to detect local underdeployment and distortion in 2 orthogonal projections. And of course, this is provisional, but if we continue provisional with TAP or culotte, we can actually follow the same steps for 2 stent procedures. And this is only for centers in which intravascular imaging is not available. I thank you very much for your attention.
Well, that was amazing as usual.
Thank you.
Congratulations. And questions, comments, if you want to say?
I have to say that Goran made a much better presentation than the one I did in the last EBC. But on this, he was speaking about the repetition of inflation. So we know that we can use the plastic characteristic of balloons since a presentation of Gérard Finet in Porto 2017, Porto meeting. So in Massy, we are inflating 2 or 3 times, always, each time 30 seconds. This is not written on the wall, this is printed in the head of our nurses. So when we say inflate, they inflate, and 30 seconds later, they stop. And this is exactly the contrary of what we see in many, many meetings, when you see the guy inflate, and 5 seconds later, click, deflated. The balloon is very far from the nominal diameter, the one you find on the box of the stent. So I think this is a very important point. And having a third inflation, in fact, you are going at a higher diameter than the one which is on the box of the company. And this can compensate the lack of the fact that the QCA measurement is 5% smaller than the OCT measurement. And it's very easy because between the 3 inflation of balloon, you have about 0.2 millimeter, 200 micron, 220 micron. And this is the definition of a malapposition, 200 micron, if I'm not wrong. 200 micron. So you inflate 1 time more, and you compensate the undersize of the QCA measurement. So this is a way to, I'm not making the promotion of not using intravascular imaging of this very nice thing to see. But if you don't have it, you cannot pay it, you don't have it, or you don't have it for all patients in your cath lab, do that, inflate 3 times, not increasing the pressure, add the pressure which is on the table of the box, and you inflate 3 times, and you will be apposed.
Can I just add before? Yeah, I just want to add. This is not presentation against use of imaging. This year we are writing 2 parallel consensus statements. So we have one on image use for optimization that we are preparing with European Association of Percutaneous Coronary Intervention together. So EBC and EAPCI are working together on image-guided bifurcation PCI. And just for everyone in this room, for our own staff in our own labs, we all detect this, what Yves has mentioned, that after 5 seconds, especially for kissing, inflate, you inflate, nurse inflates, deflate, so never more than 10 seconds. And we simply want to share with people the troubleshooting that we may perform in case of suboptimal guidance with angiography alone. So don't misunderstand the message. Lecture is not against imaging. This is just 2 parallel documents, and this one is for everyday practice in centers without imaging.
One comment. Us old-timers that grew up with thicker stent struts always knew that you had to hold the balloon for 30 plus seconds. I think it comes from there. I had one question. In the left main crossover single stent provisional stent strategy, how often were you crossing over from left main into circumflex and leaving the LAD? Because I know a lot of operators are nervous about leaving the LAD. And the second part is many of these same nervous operators will IVIS the ostium of the LAD. And there always is plaque. And then they make the argument we should do cool-out.
Yeah, thank you for that question. Actually, I chaired the 2 years ago session at Asia PCR or Asia TCT, whatever, and there was isolated ostial LAD lesion. I was chairing the session. Operator, who is known guy, presented the case, and just for curiosity, I asked him what technique he is using. My question was whether he is nailing or doing crossover, and he said decay crush. And I said, why decay crush with completely healthy circumflex? He says, it's a big branch, I want to protect it. So fear is what makes a lot of wrong decisions in bifurcation PCI, and 20 years EBC is working to help people better understand the principles and to try to share with you our own dilemmas and our own conclusions after 2 hours of intense discussion every year. So inverted provisional stenting from the left main into the circ is actually determined by plaque distribution. If there is most of the plaque in front of the ostium of the circ, we know that crossover towards the LAD will compromise circ. In that case, we cross over towards the circ, we perform optimization by pot, and we do gentle kissing with minimal protrusion of balloon inside the ostium of the LAD, low pressure dilatation just to remove metal, and then we evaluate result. If there is a problem at the ostium of the LAD, only in that case we will convert to second stent. I hope this answers.
Okay. So, just out of the discussion, because during your presentation, Goran, you said that Yves was your mentor during all this year. And I have a question now, because probably he I realized what I will ask him. Do you remember at what year was your first visit in Bulgaria, in Sofia?
We were discussing, you were not at the dinner yesterday night. So, but Valérie told me was probably 2001 or 2.
Yes.
Was at the time I was visiting, I was invited by Sasha Doganov, a very good friend, died today, but and it was in the early 2000s. So
Yes. And
you know the answer.
Yes, I know the answer, of course.
Tell me.
Because that was the time when I realized that I want to understand what the bifurcations are, because you performed the first cases in 2004, just 20 years ago, in National Heart Hospital, and I was in the public watching you,
No.
just from the fellows, yes, and then when I saw you, I just realized that this is what I really want to do.
So I am also your mentor.
Yes. Okay, so do we have the recording from the Robert? And because just one of the patients who was prepared for tomorrow live case session became unstable, and because it is a complex case, Valery went to work. This is why he is not at the moment. He's in the cath lab doing this patient. He was prepared for tomorrow, but we had to.
Find another one.
No, we have, but this is why Valery is missing at the moment, but he will come back. And now, the recording from Professor Gill.
Dear colleagues, this is a second presentation, which is very personal, for sure, and will be different compared to the others, which I was the witness during the previous symposium. Mainly, the presenters focus on techniques of treatment, decision-making process, one or two vessel techniques. That's what I remember. So my approach is different. I will try to elucidate a little bit my point of view. I don't have any conflict of interest regarding this particular presentation. In terms of coronary bifurcation, this is a well-known and accepted simple definition. This is a stenosis involving the origin of a significant side branch. Side branch means something about 2 millimeters. So this is a real clinical problem. The occurrence is up to 25%. But what we also know, there are very huge variation in anatomy due to the vessel sizes, angulations, plaque distributions. So we know about it. Simple bifurcation is relatively easy to be treated as a simple lesion. But what about complex bifurcation? Complex bifurcation means involvement of side branch, also stenosed. Then this is a true bifurcation with the more than 50% diameter reduction of diameter stenosis, with a length of this lesion more than 5 millimeters, and still with at least 2 millimeters as a vessel diameter, and of course with viable myocardium, which is very important that we shouldn't rely on the visual assessment regarding the significant side branch stenosis. We know from the work of Bon Ku from Korea that that there is a significant part of the angiographically tight stenosis without functional without functional okay. In terms of bifurcations, we know quite well that this variety means a lot of possibility. There is no two the same bifurcations. We can really find an atlas of these bifurcations individualized just by patients, not a group of patients. So we have to take into consideration. So therefore, it's very important to have the same classification. The only classification accepted by all of the interventionalists. This is a relatively simple Medina. There's no time to go into consideration. But using this classification, we can assess not only typical bifurcation, but also trifurcation or even quarter trifurcation. In terms of bifurcations, we have to remember that this is just one entity, but with three parts. So this is side branch. Oh my God! This is side branch. This is main vessel and polygon of confluence with a carina. This segmentation is very important because it's just there are three parts, and what I would like to show you, and this is my personal feeling, that the more you know anatomy, you understand hemodynamics, the better you understand how you should improve, how you should correct bifurcation lesion. So this is my point. And of course, just to understand each other, we should use the same language, the same names, the same sentences. And here you can appreciate this main vessel, side branch, and main branch. What is very important, the relation in terms of sizes. The distal is smaller than proximal, and in majority of cases, size of side branch is also smaller than distal. And we have a point of confluence, carina, as you see here, diameters, which should assess. Angiography is good for angiographically healthy vessels. For atherosclerotic vessels, we need much more. I mean, visual intervascular visualization. The angles, which are also very important, we should predict how stent implantation changes the angles, how the angle will impact the flow for side branch, for example. What is also very important that we should remember that bifurcation is a kind of visualization of fractal structure of the coronaries, and we have to remember that the size of the vessel, the diameter of the vessel, changes, decreases exactly from proximal to distal part in the course of artery. Here we can appreciate even these tapering, let's say, numbers for main vessel and for side branches. For every millimeter of the vessel, the decrease of the diameter. So this is very, very important. But of course, by and geographically only for healthy and geographically free vessels. This fractional and tapering nature of coronaries should be taken into consideration, and we know quite well that there are relations between all of these three parts and can be illustrated by different possible formulas. The formula which is simplest and very well known by interventionists, this is Finet. Our French colleague published as first these things. So it means that we have to, before decision of revascularization, we have to take into consideration that this diameter for distal part is lower than proximal, and also should be taken into consideration the diameter of side branch. For left main of very diseased proximal part, taking, let's say, having these two diameters for distal part and side branch, we can calculate from the Finet's formula the size of the proximal part. It works quite well for left main. The less atherosclerotic the less atherosclerosis, the more, let's say, precise result. What is a practical importance of these diameters? No, as I already told you, this is very important to choose a proper decision regarding the size of the vessel, the size of the stent, for example, redilatation for proximal optimal technique. What is also very important that we have to remember what are the mechanisms of changes after stent implantation for bifurcations. Here, this is the illustration of the concept of carina displacement. You see the differences between the proximal and, let's say, main vessel and main branch. You see the angle alpha, which was found by my friend Professor Vasiliev and myself. And here you can appreciate that if you exceed the distal diameter of the stent, you increase the carinal displacement or carinal shift, which can be translated into impairment of flow for side branch. Sometimes we see this pinching. So this pinching is mainly performed as done by this shift of carina. Unfortunately, we don't know without morphology assessment by intravascular visualization, but the length of the carina also makes a difference. The big, let's say, the bigger, the more it influences the flow into side branch after main vessel stenting. Sometimes we don't predict that it will happen. It happens. What is also an additional issue? This is atherosclerosis, which is located due to the let's say distribution of wall shear stress. So the less wall shear stress, the bigger facilitation of the atherosclerosis. So therefore, we don't see a very symmetric, always the same pattern of atherosclerotic plaque, but it's just let's say it depends on the flow. We love lamina. We don't like let's say other dramatic flow or aggressive flow. There are some factors which are associated with side branch compromise. This is carina displacement, plaque shift, as I already said, but also dorsal spasm, dissection, local thrombosis, and of course stent struts obstruction. And here you can appreciate that with the intravascular visualization by IVUS, you can, let's say, define and understand why this relatively good lumen for side branch after stent implantation into main vessel, it's compromised, and here we can see so-called eyebrow reflex, which is which we can very well predict with IVUS, and then based IVU, let's say the stent size by IVUS, we can decrease this carina shift, and then we can optimize by NC balloons with just to improve the flow. We know quite well that that all of these features or factors already mentioned are responsible for this side branch compromise. You see again the results of our common work with Professor Vasiliev. We found how big these differences or factors, how big they influence the final results. The measurements of angulation is also very important because, first of all, this is feasible with angiography and with computed tomography. We know that bifurcation angle means something. Let's say the narrow means less than 70 degrees. The side branch varying is easier. The carina shift is unfortunately bigger, and ostial coverage is more difficult. So it should help us to choose a proper technique due to the morphology of this bifurcation, and this bifurcation angle is also very important. On contrary, with the wide bifurcation angle, more than 70 degrees, side branch varying is difficult. So it is difficult. It also gives us information that probably we should start to treat bifurcation with side branch rather than with a main vessel. And then this carina shift is less likely, and coverage of the side branch is easier. So here you can appreciate two papers showing that these angle measurements is reliable, and this sentence, high branching angle, predicts high restenosis rates and worse survival, especially when we don't go with optimization and intravascular visualization. And also it should be taken into consideration that after stent implantation for bifurcation, especially with the two stents technique, we completely change these angles, which is unpredictable. But because of the stiffness of the stent, we change it, and of course it surely it impacts the answer, let's say answer of the vessel after stent implantation. We have to take into consideration that the orifice of side branch is changed by main vessel stenting. It changes, that the shape changes from circular to oval, but still with a still good lumen. So this is much bigger than the circular. So therefore, not always decrease the orifice of side branch after main vessel stenting means that the next stent is necessary that dilatation necessary, and so on. Just to remind you that all of these details should be taken into consideration whether we should continue or not. And of course, in nowadays we can support our decision-making process on intravascular visualization. However, only using this bifurcation angle assessment, we are able to also to predict the percent diameter stenosis for side branch after main vessel stenting. Here you see the results of another paper performed with Professor Dobrin, showing that assessing the angle alpha, as I showed you at the one of the slide, the cosinus of this angle is highly predictable for percent diameter stenosis of side branch, and based on that, we are able to propose a special score predicting potential closure of the side branch. So my take-home message is that anatomy of coronary bifurcations have high variability, taking into consideration diameters, angles, even if they are free of plaque formation, but that should be tested by intravascular visualization. This variability is further increased by pathological distortions, plaque formation, remodeling, tortuosity, calcifications. Selection of individualized treatment technique is extremely important due to the divergent anatomy of bifurcations lesions. And just my final conclusion. It's much better to think and to visualize the bifurcation in your mind before you start your treatment. Try to understand the anatomy. If you have any problems, remember, pre-procedural intracoronary bifurcation can solve all your problems. Thank you very much for your attention.